welcome again, and I'm just going to go over a few housekeeping items for everybody. Just to let you know, the session's being recorded and will be shared with you later. And we ask that everybody mute their microphone when you're not speaking to reduce the background noise. And if when you speak you unmute and you find that you have echo or audio feedback, just note there might be three causes: that you have a computer and a telephone audio active at the same time, computer or telephone speakers too close to each other, or multiple computers with active audio in the same conference room. So we just be mindful of those items so we can have a clear recording. We appreciate it.
Great. So this is Anna again. Just to run through our agenda for the day, we are continuing the conversation that we started with the last full cohort webinar, which was focused on partnering with healthcare and payers. And today we're going to be going into a little more detail around the data systems and support that's needed to put in place to support those partnerships. We have two presenters with us, and I'll be introducing them in a minute. Similar to the format last time, each presenter will have 15-20 minutes to share their slides. We'll have ample time set aside for Q&A with the panelists. And again, any questions that they aren't able to address today, we will follow up and work on getting responses to you at a later date. And then we'll take a look at that spreadsheet that you have been contributing to around the data systems that you might be using, and then point you to some more resources that we've been compiling. So that's the plan for today. I first would like to introduce you to Andrea Price. She is an RN CCM, long LTSS Director, Clinical Health Services with Aetna Better Health of Ohio. She's subbing in for her colleague Jason. She's a registered nurse with CCM certification and has worked with Aetna Better Health of Ohio since May 2014. In her time with Aetna, she has managed the community well population as well as all three of their regions with the waiver population, overseeing the AAA delegation relationships. Most recently, she became LTSS Director in November 2018. And before her time with Aetna, she worked as a care manager at the Dayton, Ohio AAA. So I'm going to pass it off to Andrea, and then we'll introduce you to Sharon Fusco.
Hello. Nice to be here with you all today. Okay. So I'm from Aetna Better Health of Ohio, and we have a unique partnership with our area agencies on aging here in Ohio. Just a little bit about MyCare Ohio and our plan that Aetna Better Health of Ohio is a part of. It began in 2014. It is for members that have dual eligibility if they have Medicare and Medicaid here in Ohio in certain service areas. And that map you're seeing of Ohio there, they have to live in one of the counties that's shaded. The different colors are the different regions. So Aetna Better Health of Ohio is in 3 regions: Southwest, which is indicated with the SW, those 5 counties; Central, which is indicated with the green shading; and then Northwest, which has the blue dots, the NW. The point of MyCare Ohio is for our members to have one point of contact. So they wouldn't have to call their Medicare insurance and then also get something through Medicaid. If we cover both their Medicare and Medicaid, then they just have one point of contact, and they can do that through their care manager. We have in our Aetna has about 14 counties, and our waiver membership is about 6,500 members. Overall, we have about 26,000 members, but we work with our local area agencies on aging with about 6,500 of those, which is our waiver members. In our central region, we have about 72% of the waiver market share over our competitor. In Northwest, we have about 60% of the market share in waiver over our competitor, and then in Southwest, we have 61% market share of waiver over our competitor. So we coordinate and reimburse for the services and care our members need. So for our waiver members, you see up there, we coordinate with the AAAs. We actually delegate our care management to the AAAs in our 3 different regions that we have this plan. We also have supports in place for behavioral health. We also help them coordinate with their primary care provider, any social services they need, home health they need, community services, and transportation. So as I mentioned before, we do delegate full case management to our AAA partners for our waiver members. This includes members that are under the age of 60. So this could be anyone from 21 up. This is a contract that we have with them, and we also have a contracted LTSS provider network. It's per member, per month reimbursement, and we have a value-based shared agreement in development. Actually, since this slide has been created just a few days ago, we've actually implemented that value-based shared agreement. We do have Aetna dedicated liaisons. So for each of our AAAs, they have a point of contact that's dedicated just to them and our relationship with them with each region. As I indicated before, we have top market share in those regions. And then we have a high duals opt-in rate, which means while all our members have to be eligible for Medicare and Medicaid, they do have a choice. If they don't want us to have their Medicare with us, they can opt to have their Medicare with a different provider. Opt-in means they've opted for us to have their Medicare. And then rebalancing. This is repatriating our members that live in a nursing facility long-term into the community as appropriate with those services. And that is mainly through waiver services. And then we have a very high amount of member satisfaction, which is demonstrated through our market share. And then with our relationship with the AAAs, we actually, they have 140 dedicated FTEs at the AAAs. So there's 3 different AAAs, and overall they dedicate 140 staff to our relationship. So some of the things we looked at when we were choosing organizations we'd like to partner with was definitely the ability to comply with regulatory requirements. We wanted to make sure they were a respected community organization. They have competence with the population we serve, a visionary leadership, and then also nimble governance. Can they change very easily as our contract with the state changes? Are they able to change with us? And then are they a collaborative partner? If they meet all those criteria, then we explore a partnership. Some of the lessons we learned, definitely communication, problem solving. We actually have implemented a monthly meeting with our AAAs where the AAAs come on site here in Columbus along with their liaisons that work on the Aetna side, and we have that monthly meeting just to make sure we're all on the same page. System access and security, I'll get into this a little bit in a future slide, but one of the things is what databases are we going to get access to for them? How are we going to make sure that we have security with them working on their own computers? and we do that through a VPN. But also, when you're working on a VPN, do you have adequate bandwidth to withstand that? Shared policies and procedures. We have Aetna policies and procedures, but that organization needs to develop our policies and procedures into their own internal policy procedures. And then delegation oversight. How are we going to be overseeing that delegation partnership and making sure we're all in compliance? We do have regulatory audits, quarterly actually, in the state of Ohio, so we're definitely being looked at very closely. And then also, this helped develop clinical expertise and staffing with our AAA partners. And then sharing that training expertise. We have training that we've developed here at Aetna and how to best train their staff. And then, as I mentioned before, we have a value-based reimbursement agreement that is newly put in place. As I mentioned before, technology, which systems to use, who has access and to what information, firewalls, just to make sure that we have that enhanced security and that our members' PHI information is very secure. Network bandwidth, that's one of the lessons we learned at Go Live. We had some issues with one of our regions didn't have adequate bandwidth for all the VPNs coming on to serve our members on their computers. So we had to quickly help them troubleshoot that and had to quickly increase their bandwidth because the whole network got shut down after Go Live for several days, and that caused an interruption. And then proper security protocols and secure environments. Audits and reviews, we actually do internal delegation audits because we don't want to be surprised by anything in a regulatory audit. Definitely NCQA requirements, so we are NCQA certified, so we needed to make sure that they were able to meet those NCQA requirements. And then also, as I mentioned before, we have our own internal policies and procedures that we share with our partnering organizations, but they had to come up with their own as well. Yeah, so there was a question about the security of the databases. So some of the things, we have some internal databases that we can firewall off, that our AAA partners can only see their members. But then Aetna has a database that can't be firewalled off, that if someone has access to this database, you have access to everyone in our membership. And so that's one of the things, the challenges, that we were not allowed to share direct access to that database with our AAA partner because of that. So what we did, because they still need the information that that database provides, we actually worked with our reporting team so they could pull the information for those members they serve out of that database and give that to them without them having direct access. That was a lesson we learned, and it definitely enhanced our relationship when we were able to give them that needed information. About the NCQA accreditation, Aetna.NCQA accredited, and we had to have our AAA partners help because we fully delegate our case management for our waiver members through that. The AAAs, if they were to get NCQA accreditation on their own, that would be separate, but we did have to have their help with our NCQA accreditation. So realizing some of the partnership benefits, for the AAAs, it was to help diversify their programs, expand their revenue sources, enhance their clinical expertise, and increase their employment opportunities for their staff. For us at Aetna, we got to leverage community-based expertise in staffing. The AAAs have been doing this a long time, serving members of the community, and we didn't want to we wanted to recognize that expertise and partner with that. Also rebalancing, as I said before, moving people out of a nursing facility that's lived there long term to a more appropriate setting with the supports in place. This has actually helped us be more successful in that area. And then support member enrollment and retention. We have a higher market share because members are very satisfied with this agreement. And then a single point of contact for the member. Our competitors do not fully delegate their case management to the AAAs. They only do the minimum that the state requires them to do. So a member that is with our competitor would have a care manager through their insurance plan, but then also have a service coordinator through the AAAs, whereas if a member had us, they have one point of contact because their service coordination needs are met by their care manager at the AAAs. Okay, and I did see some questions. I don't know if we're going to do the next presentation before I get into the answers, or how we're going to do that.
I think, Andrea, it'd be great to wait until Sharon presents, because there might be some questions that both of you could address together as well.
Sure.
Okay, great. Thank you so much. Now we're going to pass it to Sharon Fusco. She's Vice President of Innovation and New Business Operations at the Council on Aging of Southwest Ohio. And this role includes core functions of innovation, lean and leading edge initiatives, new business operations, project management, and technology services. She currently oversees Positive Choices, COA's newest initiative that provides coaching and support to individuals with a variety of complex health needs. Sharon also serves as the COA's security officer. She is an entrepreneur who has focused her career on maximizing the potential of disruptive change within organizations. So we're really excited to have Sharon join us today. She has a wealth of knowledge, just like Andrea, to share with this group. So we'll pass it over to you, Sharon.
All right, thank you for that introduction. And Andrea, I haven't talked to you for some time, so congratulations. I understand you've been recently promoted, so couldn't have thought of a better person to take that job. So good on you. All right, I don't have controls yet. I'm not seeing them.
You should, there you go.
Oh, there we go. Thank you. All right, so I am with the Council on Aging. We serve a 7-county region in southwestern Ohio, and whoops, I'm still having issues. I don't have back and forward buttons, it doesn't seem like. Our mission is to enhance the lives of older adults and people with people with disabilities, to help them remain independent, and we do that through a wide range of services. But I'm here really to talk about our experience with technology, and specifically how it has been working with managed care companies, of which Aetna has been one. And so just to sort of tie into Andrea's presentation, a couple things that we learned, from that was that, I know going into the MyCare arena, we had hoped that managed care companies might be interested in using our system. We have a very robust care management system. We use it to serve about 17,000 of our clients. And what we realized very quickly was they really wanted to they own the data, it's their data, and they want us to use their system. So if you're contemplating buying a system, make sure that you've thought about your product lines and whether or not your potential customers are really going to be interested in using your system. The second thing that was kind of a lesson learned, and I appreciated that Andrea talked about their data structures. I almost feel sorry for Aetna. Aetna and our other managed care companies that we worked with under the MyCare program, because we beat them up pretty hard because we were used to having our own data, and because we had our own care management system, we could access anything we wanted. And it took us a while. It was a little bit of a learning curve for us to realize the heavy amount of regulation that these managed care companies are under and the security levels that they must maintain. They were very different than what we had been, and that there's been a blessing in this, and that we've updated and upgraded our security to be more in line with that. But it was something we didn't understand when we said, well, just give us the data, it'll be easy, you know. And it's far more complex than that, because these are very large organizations, and they have, you know, their systems and their rules and the level of scrutiny that they're under. I don't know that we fully appreciated that in the early years, and it wasn't really until Aetna was able to make that data available to us, and we began to understand, and we began to really work on our own security, that we understood how much scrutiny they're under. So just something to kind of be aware of. The other thing along that line is, when you ask for something, you have to be prepared to use it. And, you know, I can remember when Jason at Aetna first said, hey, we're going to build this report for you. And Suzanne immediately turned to me, because at that time, the analytics department reported to me, and she said, now that means you have to be able to use it. You have to put it into, you know, you have to make the tools and the things that the care managers need to use that data. And you have to train up the care managers on how to use that and so forth. So it was a great lesson that, you know, it's one thing to ask for it, but then be prepared to use it, because there's great data there, and they did a great job of giving us what we needed. But we needed to make sure that our people were trained on using it. The next thing that we learned through that process was having a champion at the managed care level was really important to getting us what we needed. So I would say that Jason did a fantastic job, as did Andrea, during the implementation of making sure that, you know, they understood what we needed, they understood the value we had, and therefore advocated on our behalf to get us what we needed to do a good job for them. So find that person. If you're working with managed care, find that person. So Antonia asked that I talk a little bit about purchasing technology, and we've purchased a lot over the years. I personally have been involved in 2 major care management system purchases and installations, major implementation for our business intelligence team, financial software, and we're currently in the process of another new big infrastructure technology that we're putting in place for a brand new line of business. And we're implementing a new learning system, and then there's been many, many small ones down the line. So the lessons I'm going to give you are sort of from that experience of what have I learned over the last 10 years in getting to implement new systems. And I think, you know, one of the first questions that we had to ask ourselves with each one of this is, do we build or do we buy? And there are benefits to both of them, but there are cons to them as well. You know, building certainly means that you end up with a nice proprietary system that you own. And there are business models out there that are built on that competitive edge, but you have to decide if that's what you want. Buying a system allows you to adopt to industry standard, and when you buy, typically you get the benefit of the upgrades of the, you know, as the industry changes, your software is keeping pace with that. And so building, you know, when you build, you've got a lot of maintenance expenses, and who's going to do that, and who's going to actually work on your system. If you buy, that kind of comes with it. So, you know, there's benefits and cons to both. You know, the other downside to buying is that it's usually less flexible. There's only so much customization that you want to do on a system like that, because the more customized it is, the closer you get to building, and again, you start moving away from that core product, and pretty soon you find yourself out on a limb by yourself. We've had that experience where we customized something beyond the point that they could keep it up to date with the rest of their service products, and it put us way out there, put us way out at risk. So you really have to think about build or buy, and it really kind of comes down to what is your business model and where are you going in the long run. The second thing that we learned is really take your time to do specifications and do them well and think them through. And at the end of the day, you start at the end and you work yourself back. And the end for me is always the data. It's always, what do I want to do with the information I'm capturing in the system? If I'm capturing it for billing, am I capturing it for performance? Am I capturing it for documentation? What are the audit requirements and so forth? So really starting with the data and how am I using it, and then building your specifications kind of backwards from there, taking into consideration your processes and things of that nature, your contractual requirements, what do I need to capture to be in compliance with Aetna's specifications or whoever it is that you're working with. But it all kind of comes back to that data. And so you really have to work yourself backwards from the very end when you're building those specifications. There are some things contractually that you can do to help with that, depending on how much expertise you have in building technology specifications. We've done things where we've brought in people to help us with that. We also had one software vendor that we thought we would use, but we weren't sure if they could do what we needed done. So we contracted with them first just to help us build specifications. And then we were able to see would their software meet this or not. And if they didn't, we at least ended up with a nice set of specifications and were able to shop that. As it turned out, that company did not meet our needs, but we were able to use the specifications that came from that. So speccing out your system is a lot of work, but it's important that you kind of get it right. Along that line, I would say the other lesson I learned here is don't let your staff get trapped in the box that they're in. So they're used to doing business a certain way. And when you're talking about a computer system, to help you with that, make sure that they're not trying to replicate what's done today, especially if you need to start adopting new practices and be more on the cutting edge of innovation. Sometimes you have to help your staff get out of the box that they're in. And I would say we've only been partially successful with that. We, recently in this latest one, there were a couple opportunities that we missed because we weren't thinking out of the box enough. And so just a heads up there, people try to make the system do what it does today when actually you need a system that will do what you need it to do tomorrow. Getting a solid contract will help you in your purchasing process. Vendor selection is everything, and your contract is what's going to kind of make or break that relationship. Having a contract that, a good contract to me is one that's balanced in terms of everything from indemnity to, privacy protections, but also around making sure that you've got a good scope of work outlined and or that your contract says we're going to have a scope of work that we agree on by this time, because sometimes you need a little bit more time for that scope of work. But making sure that that scope of work is really well defined all the way down. I mean, I've got some that go all the way down to we will take minutes at every meeting. We have a change order process. So you want to be pretty specific, and a change order process, a quality assurance process that the company will follow, what your expectations are around their project management, as well as capturing what they expect of you as the purchaser. What do they need from you? We have included penalties as well as incentives for delivery of milestones. And yes, I've had to exercise those. So it's been helpful to have them in the contract. So, I usually the first contract that I see is usually not strong enough, and it's usually one-sided for the vendor. So don't just take their contract. My advice is to really scrutinize that contract, bring in some legal help to you with that. One of the first ones we did, we actually brought somebody who did legal work for technology companies, and I highly recommend that. So really make sure you've got a contract the way that you want it to be, because you may need it. Lesson learned from experience: be careful of vaporware. If you haven't heard what this is the salesman that comes in and says, yes, this is all the wonderful things, and shows you all these bells and whistles. But when you lift the hood, there's nothing there. And we had a situation come up where it was an existing partnership that we had. We were upgrading to their latest service, and basically what they said is we want to upgrade you once and then upgrade you a second time to our latest and greatest version. And so they showed us all the bells and whistles of that latest and greatest version. And they said to do this, this would be the best and safest thing to do for your data migration. Well, they got us to the first step, and then we began to realize that that second step had yet to be built. The reason that they weren't moving it faster for us is because it didn't exist. And then as we learned that they finally had customers on that, when they finally did get it built, it didn't work. And so that was quite an experience and a very disappointing one. And at the end of the day, we didn't get what we needed. You know, they lost a customer for life. We'd been with them for almost 20 years. So that was a hard way to learn it. So really taking time to check references and really make sure you're seeing the system live someplace else, that you're not the guinea pig and you're not the one that they're going to build this for, but that there really is an engine under that hood, and that engine works and is of a size and comparable agency to your size. So that was something else we learned, was that, you know, like they would show us something, but it might be somebody who handled 500 clients when we have 20,000 clients that we need served. So just making sure that it can handle your size of an organization. Time and money. So there's a couple points here. You know, software vendors can do anything you want them to do. It's a matter of time and money. And both of them are, you know, just be aware of that. They will say yes, and just make sure that you're taking time to figure out what are they saying yes to, speccing that out good, especially when there's change orders. How much time is it going to take, and what's it going to cost you? And sometimes you have to evaluate. Sometimes you have to give some things up in that process. The other thing I would say is don't go, you know, figure out what you can spend, and don't go cheap on it, in the sense that these systems are big and they are expensive. And so you know, you're going to be making an investment, but it's an investment over time. And make sure you use your contract to hold your vendor accountable. And we did this, like I said, through a number of things. The other thing I'd say with time is that, you know, it can take, like our last care management system, the one that we just finished implementing, we started that process about 15 months ago. It took us, you know, 6 weeks or so to get to a good contract terms. You know, it took us almost 4 months to do the design. Once they started building, we started working on data migration, realized we've got a heavy lift on our data migration. We ended up slipping our timeline, you know, 3 months. It took us about 12 months to implement that system, and we're now in the post-implementation, which is probably going to be to really get from where we are to where we need to be another, you know, several months. So, which speaks to the next slide, which is it's one thing to implement, it's something else to optimize. And when you're thinking about your project, yes, you want to get to go live and you want to get things smooth, and you want your implementation to end when your system is running smooth as it was designed. But I will tell you that to really get the most out of your investment, you're going to have to go into a second phase, which may take you another year, which is about optimization. How do I really maximize everything this is? Because when you're designing it, you're still kind of in that mode, this is how we do business today, but your system's going to give you opportunities to do things differently, and it takes time to build those processes around that to really blow out the whole functionality of the system. So just kind of keep that in the back of your head as you're moving through this. I would say that the other thing that has really helped us in our implementation is having really good project management. And that's not just on the vendor side. You want them, you know, make sure you get a project manager that you like and that you can work with on their end. And I will tell you, I have asked vendors to give us a different project manager because the one they had couldn't keep us on track and couldn't keep his team on track, and or was over-promising and under-delivering. So make sure that they've got a good project management, they've got a good project plan, that they've really thought out those timelines, that it's really feasible, that the deliverables that they're going to do make sense in the time that they've allowed to deliver them, those kinds of things. Likewise, make sure you have a project manager that can work with their project manager to keep your internal team on track, because it's no fun telling a vendor, well, we're just not ready. You know, you want to make sure that you've got somebody who's really organizing things on your end, and there's a lot of internal movement that happens and activity that happens around these system implementations. So having that on board is good. And that's about all I have. I wanted to leave a lot of time for questions, so hopefully I've done that. I'm open to answering anything that y'all have, and that's our main office number where you can get in touch with me.
Great, thank you, Sharon. So I know we had one question that came in for Andrea, and then I have some questions that I'm sure people are thinking about what they might want to ask. The easiest way, you can either raise your hand and your line should be unmuted, so you can ask a question that way. If you're in a space where that would be challenging, you can also ask it in the chat box. So our question is from Jennifer in Oregon, and she asks to Andrea, does Ohio require Aetna to work with AAAs, or was this a voluntary arrangement? And if so, does Aetna also contract with other partners instead of AAAs to cover other parts of the state?
That's a great question. And so according to our contract with the state, they require all of the MCOs to work with the AAAs in some regard. The minimum is with people that are over age 60 that have waiver services, they have to work with the AAAs to have a service coordination. Aetna decided to expand that, and we actually delegate full case management, including service coordination, for all waiver members, even under 60, for our plan. So our plan only serves 3 regions of Ohio, the Southwest region, the Northwest region, and the Central region, and we work with all 3 of those AAAs in those regions. We work with the Northwest AAA, the Central AAA, and then the Southwest AAA, which is also known as Council on Aging. But so we don't really have that agreement with another organization besides the AAAs.
Can I add, just so folks know, we, in addition to Aetna and the MyCare and the waiver services, we do have separate contracts with managed care companies for other services, and those are not mandated by the state. Some of them are on their Advantage product lines. Some of them are on other Medicaid services that they provide. So we serve as a contractor to managed care in a number of ways. So it is possible to do it without it being mandated.
Great, thanks, Sharon. Andrea, I had one more question for you, and then I think we have a question for Sharon as well. Just kind of go back and forth. On your slide 5 about choosing partner organizations, and you spoke to some of these criteria that you're looking for. Can you talk a little bit more about how you assess, if the organization has visionary leadership, nimble governance, if they're a collaborative partner? Is there any type of checklist or just insider knowledge as to what you're looking for, so that any of the organizations in the Learning Collaborative can think about, how they might meet those criteria with MCOs in their own communities?
Sure. Now, I will tell you from my experience, before I was with Aetna, I worked for a AAA. I actually worked for the Dayton AAA, and we knew MyCare was coming down the pike. Some of the AAAs were more accepting and collaborative of that coming, and others were really just trying to push it and not collaborate with the MCOs at all. So definitely we look for someone that is open to a collaboration. If someone is just fighting the legislation and trying to stop it, definitely that makes an impression on an MCO. So we need to make sure that with our talks with different organizations, do they seem like someone that, an organization that has that leadership that can see, yes, we need to collaborate, we get what you're trying to do, we want to work with you? That's the first step. And then as you explore a partnership, you need to make sure the other boxes are checked. It was no secret before MyCare came into place that it was coming, and it kept getting pushed off. And being from the AAA world, I saw firsthand different regional AAAs really fight it and not even attempt collaboration at all. So I think that would be the first step, is an organization looking collaborative. And then at that point, you would go through the other check boxes. Hopefully that answers your question.
Yeah, no, that's very helpful. So our next question, Sharon, is if you can talk about the IT vendors that you're using now, and I'm just going to add a little bit to that from our conversation with you. I recall you mentioned, there really is no such one data system that works for everything, and you spoke a little bit about different systems you're using for care management versus for data reporting and analysis. So I think some of the communities are just interested in hearing specifically about certain vendors or products that you're familiar with. And this question comes from Nikki in Western New York.
Good question. So yeah, our most, the system that we've just purchased and actually just finished implementing, like I said, we're in the throes of the aftermath of go live right now, is Care Director. And it is a system that provides not only assessment, care management, but also does the service authorization, claims adjudication, and billing for our providers. So it's kind of it's a unique system in that it's an all-in-one system. Many large organizations actually split their claims processing from their care management system. So, the systems that have those combined are rather unique. And so there's not a huge number of them out there, I don't think. I mean, we maybe found a dozen of them that we examined when we went through the process of selection. For our data side, we have traditionally been a SaaS Enterprise Guide shop. We purchased that back in 2009. We are in the process of really evaluating whether or not that's a platform we want to stay on. A lot of our, for example, our care management system is SQL Server based, a lot of SQL reporting. It does a lot of that if you have those programmers. But I would say the key to the analytics shop, it's great to have the analytical tools underneath. SaaS Enterprise is a great tool, requires, some knowledge to run it, but it's really the people, the analysts, that really make the analytics shop work. And it's, the technology is kind of secondary to them. It's really, the skill level of those individuals. And we have, 4 dedicated analysts, probably could use a dozen of them if I had them, and a data architect. And they are separate from our IT unit intentionally because we wanted to focus on analytics. And sometimes when you combine those with IT, which some people do, there's you don't get as robust a set of data from that. So we've separated out intentionally and put it with our quality teams and things of that nature that really work on performance and analytics. So other software that we use, again, we use all of the ones that the managed care companies use. For our Medicare Advantage program, that's one that we use our Care Director program for, so we get to use ours for that contract. And then we also have things like Financial Edge for our finance, our accounting team and our financial analysts, and we use Relias for our learning system. So those are just some of the systems we have.
Thanks. And then in follow-up to that, is the new system, I think you said it's Care Director, is that able to link directly with your MCOs and other clinical partners?
So we have not, well, for that particular, for the, I'm sorry, bottom line, no. The bottom line is that we don't link them up at this time. Could we potentially? Maybe. What we, again, with the MCO whose program we're managing through that, we just provide them the data and they're fine with that. And for the programs the other programs that's running, it's just not necessary because of the structure of those contracts. So it does connect directly to our data store. So we do get feeds into our data store. So we have a SQL server-based data store where we house all of our data and use that for analysis.
Great, thanks.
We want to just open up the phone line if anybody wants to unmute themselves and ask a question.
Hello, this is Tom Waltz in Vancouver, Washington. And my question is for Sharon. I think I heard you mention something about business intelligence software, and I'm wondering if I did hear you correctly, what software you're using.
Yeah, that's our SaaS Enterprise Guide, and it is for business intelligence. And again, we're getting ready to evaluate whether or not we want to stay on that platform or if we want to move to something that's SQL-based. There's a number of reasons for that. One being the cost of training somebody in SaaS is pretty high. It's a pretty specialized sort of field, and sometimes what we find is we train them up and then they go off and find another position where they get paid more because they're now very hot in the market. And though SaaS is a very powerful tool, so we're looking at options around that right now. We've had it for about 10 years, and so it's a good time to evaluate whether or not we want to stay with it.
And a follow-up question: are you currently looking for another BI software package?
We're not. We're just evaluating whether or not we want to stay with SaaS or if we kind of want to switch things around. I would say in addition to SaaS, we also use GIS software, Geographical Information Systems, that helps you put data over maps. We've used some, smaller tools like Tableau. I've got some pretty incredible Excel programmers back there. They've done some things with Excel I didn't know you could do. So we've used a wide variety of tools but SAS is the primary one.
All right, thank you.
Thanks, Tom. Anybody else have any questions?
Well, I have one while you guys are thinking. So Andrea, do you mind talking a little bit more about those value-based payment agreements and what that looks like? I'm not sure if in all the states they're at the same place, but just for background information, that would be helpful.
Sure. We actually have these agreements with several providers, so definitely different physician groups and things of that nature, but we've most recently implemented this with our AAA partners. And they have things such as reduced readmission rates. We pay if there's an additional amount over their regular contract with us. If they hit a certain mark, we pay this PMPM for that value-based agreement for different things like readmission rates, and I'm trying to think what else. I think there's 2 or 3 metrics that we measure, and we just implemented that, so I guess we'll see in a year how successful we were with that, but it's all a common goal. This is something that is helping our members, stay out of the hospital. It's helping us, and it's also we want to share that that savings on with our AAA partners and help them celebrate by helping us save money. Hopefully that touches on what you're asking.
Great. And Sharon, we know that some of the communities are in the process of figuring out, like you were discussing, build or buy. When do we know we're ready to move forward with a particular vendor? Can you talk a little bit about balancing being in this kind of catch-22 of when you're ready to go, but you can't anticipate what you need the data system to be able to do in the future. When you have your specs of what you think you want it to do, so when do you get past the paralysis of, mapping the unknown or planning for what you don't know?
Oh, that is such an awesome question, and I'm in the middle of that right now, so it's a very timely question. I mentioned early on that we have a new business line that we know will be built on the technology platform, and so there's so much, as we've gone through the process of designing what we think we need, and then listening to the different demos of the different systems that are interested in working with us, you begin to realize just how much you don't know about what you're moving into, and it's like, ooh, am I going to make a mistake? And am I gonna spec out the wrong thing? And and then you start playing the what if games. And so I've been there, and in fact, in the care management system that we just purchased, we had a period of time where we had a manager over that one of the critical departments leave, and so staff were sort of engaged in very heavily in the specification process, and I think a lot of them were paralyzed by that fear. It's like, I don't want to make a mistake, and so what I would say is, first, it doesn't matter how well you prepare, you're going to miss something. You're going to design it, and you're going to get to go live, and you're going to realize either you did it wrong, or you missed something, or it doesn't work as you anticipated. So eliminate that fear, because it's going to happen. It's just a reality. And that's why you budget for an overage. Budget that you're going to miss stuff, and make sure that your budget isn't just what the software costs you and what your soft costs are, but budget some in for the things that you can't predict. The more unpredictability, the bigger that contingency has to be. Usually we say 10% here, but in this project where it's a brand new line of business, I'm going to ask for a lot more in that contingency bucket, because I just don't know. The second thing I do to get over that is think about how I'm contracting. If I really don't know and really feel like I want to make sure that my budget's good and that I'm thinking everything through before I go to my board and ask for this big chunk of change, then think about how you might work with that vendor to say, hey, would you come in and spec it with me? And then, we come up with a really solid scope of work, because I don't know what to ask for right now. Help me spec it, and then give me a final price, and then we'll move on with the rest of the project. Another thing to do at that point, which is something we're doing, is we're purchasing industry expertise, and I'm doing it through the vendor that we're looking at using, plus I'm going out on my own and getting some of that. So I'm doing it in two ways, so that I get that sort of infusion of knowledge that I'm going to need to have to spec this out. So, think about how your contracting can help you. Think about how your, how you roll out the project, how you can use that in the process, and then, how can you buy expertise to help you. But don't ever go in thinking it's going to go live and you're not going to go back and figure out that you've missed a whole bunch of stuff, because that's just part of the process.
Great. So we learn as we go.
Always.
Yeah. Another question from Sue in Maryland. Do you partner with your state health information exchange to share hospital or ED data? Do you guys have an HIE? I guess you have multiple HIEs in Ohio, but can you speak to that a little bit?
I certainly can. Cincinnati has a pretty robust in our region. So what I understand is that Cincinnati has an HIE, and then the rest of the states on another one. At least that's the way it used to be. So in Cincinnati, we have a company called the Health Collaborative. They have a platform called HealthBridge, and we do partner with them. And in fact, I think Aetna is a part of this, and Aetna might be even working. I know Jason was having some conversations along this line, but we've partnered with them to give us alerts on our clients and they let us know, so they're automatically generated. When somebody goes into the emergency room or the hospital, we receive a notice that says Susie Bag of Donuts is at XYZ hospital. And that allows us to dispatch a care manager or a health coach or, whomever to the hospital. In some cases, we have care management staff already in the hospital, and so they just walk down the hall to go see that person and see what we can do to assist them. So that's kind of how we work with the HIE in this process, and they've been very helpful in getting hospitals to buy into that with us.
Great. And then Andrea, I had a question going back around your technology discussion. So I know you talked about how a lot of, the data is firewalled at Aetna, and the AAAs only have access to their member data, but that you're able to, from other databases, pull reports based on the request of what outcome reports the AAAs might need. Can you talk a little bit about if there are particular data systems that you like to see the AAAs using on their own side, or if you have experience around how they're using those reports? I mean, I guess that kind of goes back to what Sharon talked about earlier, but just anything around, what your expectations are when you're partnering with the AAA, what types of data systems, at minimum, you want them to have in place to be able to use that data that you share back.
Yeah, so they use our database systems, our care management documentation systems, and things of that nature. But our most important thing is compliance. So if they have a different way to track and make sure they're being in compliance with our contract, that's fine. The information we actually had to siphon out to give them had to do with claims. So we wanted to make sure care managers could check to see if their members are receiving the services they're authorizing. So if that's why we had, and since we pay the claims, we had to make sure we gave them that data. But beyond that, I believe there are some other reports that our partners have developed to make sure that are they seeing their members on a timely basis? Are they following up? Are they doing these different compliance areas? So that's our most important driver is compliance. And you can use our systems, but if you want to do something in addition to help support compliance, that's important to us.
Thanks. And then we just wanted to open it up one more time to see if anyone else has questions for Sharon or Andrea. And both of them have a wealth of knowledge, even if they didn't touch on a particular topic here in their slide deck today. I'm sure they'd be willing to take your question.
This is Tom in Vancouver again. I appreciate perhaps the opportunity to follow up, Sharon, with you regarding some of our I think overwhelming feelings of doom and gloom regarding our ventures into the data world. We're a AAA, but we're fairly small, just north of Portland, Oregon, with about 5,000 clients, and we generate a lot of data, but we don't use it. And so we're sort of in the area of interest where we could get access to our data and be able to use it. And so we're just neophytes and learning a great deal in the process. So thank you both for your participation.
Yeah, I'd be happy to follow up with you at outside of this at any time. So feel free to get in touch with me. I've been where you were at. I started our BI unit here, and so I know what that feeling looks like, and it's not all doom and gloom. It's actually a whole lot of fun.
Okay. Everybody, well, that's fairly consistent with what others have said, is that enjoy the ride, have fun with it. So I'm taking that to heart.
Thank you. And I'll just piggyback on that and say, if there are others on the line that would enjoy listening or being a part of that conversation, we can help facilitate a small group meeting with Sharon on that particular topic. Okay, so any other questions before we move on here? Great. Well, thanks again, Andrea and Sharon. We really appreciate the experience and content that you shared today. So what we want to do next is quickly take a look at the technology matrix that some of you have been contributing to. We mentioned this on the last call. It started as a template created by Nikki at Western New York. And we've asked all of you to go into this Google spreadsheet and list a software vendor or product that you either have experience using now or that you're currently vetting or considering for purchase. So at the top, we just have different criteria of that system, what you're hoping it would be able to do, and then space for notes in the far right column here. So I know we have some additional contributions that have been added, and just encourage everyone to continue to go in and add your experience with these platforms. It looks like Thracy's is one that a number of communities are considering. And I also just want to say that this second tab here, attributes or definition, Nikki kind of just put this together quickly from their community's experience, but if you have more detailed definitions for the types of attributes you're looking for, feel free to go in and add that here in terms of, you know, when you think about user friendliness, like what specifically are you looking for there? Or, you know, what would, for your community, when you think of no or low cost entry, like what budget defines low cost? Just so we have a little more specific criteria here to share with each other. So that continues to stay on the drive. And then we're just going to point you to a couple of the other resources. We really appreciate that everyone has been responsive to requests for information. So I know Tom received a couple examples of job descriptions for data analysts. So those have been posted in the online all-in community. Because we have a little bit of time here, I just want to see if the Lutheran Services of America team, during our last work group meeting, were interested in getting some support around consent, and particularly looking at HIPAA and CFR 42 for behavioral health. I know that they spoke with an attorney at the Network for Public Health Law, and if you wouldn't mind just sharing a few takeaways or high-level learnings that you gathered from that call you had this week with Denise, that would be super helpful. Sorry to put you on the spot. Is that Matthew? I think we might have Matthew on the line.
Matt, if you're speaking, you're on mute.
Okay, well we can also share that information at another time. We also completed, actually, I think we did our office hours with all of the sites this time, so that was helpful to hear specifically from each of your teams, you know, where you are in the process of implementing your work plan and what particular challenges you're facing right now. The other important thing to highlight here that we're super excited about is that N4A is simultaneously hosting a Trailblazers Learning Collaborative, which has been underway for a bit longer than our group. And we think there's an opportunity here to connect you guys with that learning collaborative. It's, I think, another group of 10 CBOs and AAAs primarily. So we're going to invite them to join the May 1st full cohort webinar, and we're still thinking through what that might look like. But if you have ideas, send them our way. But I think, you know, this group is a little bit further in terms of their contracting and maybe looking to our group to learn a bit about data systems. So stay tuned for more information about that. We do have some basic information about that collaborative that we can share with you in the meantime to get familiar with those sites. So our next work groups are scheduled in April. We will be reaching out to some of you to do community presentations and the peer consultancy model again. And the online platform, you know, is always a space where you can go at the end of this meeting and you can find the recording and the slides from today. We will also compile a lot of the tips and takeaways that Andrea and Sharon presented today. And we might have a few follow-up items for each of you via email. And please don't forget to take the
Evaluation.
that pops up, the evaluation that pops up at the end. So thank you so much. We appreciate it. Bye-bye, everyone.
Bye.
Bye-bye. Thank you.
Bye.
Bye.